Hey everyone, my name is Dush. I'm a final year medical student at Liverpool Hospital. For those of you who I've met, hello. A lot of you I wouldn't have met you before, but hello to you too. So this is a new idea I thought of, and it's something that I hope will help you in your course of studying for the biomedical science exam. Normally, Liverpool Hospital, Southwestern Sydney Clinical School has a great culture of older students helping younger students. I know a lot of the most important things I learned, both medically and for the biomedical exam, were taught to me by older students, and I'm really the student I am today because of what they taught me. In the same sense, there's a lot of keen students in our year who I think will be hoping to teach you whatever they can this year, and I encourage you to go to every tute that you can and really practice talking as much as you can in these tutes. At the end of the year, your exam will be a Viva exam. There is no point staying in your room and studying, and really I encourage you to try and go to as many tutorials as possible and get used to talking medically, because that's what it's going to be at the end of the year. The reason I'm doing this is really to economize your time and my time. I think a lot of the times when the 6th year students give tutorials, they're quite content heavy, and I think sometimes content may be better studied at your own time, in your own convenience, at your own pace. And I think the tutorials would be best spent if we spend them practicing answers. That's why I'm going to try to make a video before every tutorial we have. The video will include all the basic principles of the concepts that you need to deliver good quality answers. And quite often in these videos, I'll be explaining these concepts much more thoroughly than you'll ever be able to deliver in a 8-minute Viva station at the end of the year. And it's really hopefully to build a foundation and an understanding of content. I really hope this helps. It's the first time I'm doing it. I would appreciate any constructive feedback you may give. Likewise, if you have any questions about specific things in this video, I think the tutorials which we'll have next week at Liverpool will be great to discuss those things, but also, again, to practice delivering answers with the belief that you've already watched these videos. I think videos are much easier than reading sometimes. I remember when I was in 5th year, I'd get home quite late from hospital sometimes, and I never liked going to tutorials without sort of knowing a little bit about the content before. And so it would be quite stressful trying to read enough to be prepared for a tutorial where I wanted to participate and I wanted to give answers. I hope that these videos before tutorials will be able to fix that problem. I look forward to your feedback. Thank you. So before we actually start the case, I just wanted to speak for about a couple of minutes on acute shortness of breath, because it's a concept that comes up in this case protocol, and it comes up in a number of other case protocols. There's a case protocol about anaphylaxis, there's a case protocol about asthma, there's a case protocol about COPD, there's a case protocol about myocardial infarctions, all of which include patients that present with shortness of breath as one of their primary symptoms. So I think it's really important, given at the end of the year you're going to be sitting a Viva exam, and that the better students come with a system to actually establish a comprehensive system of going through differential diagnoses for shortness of breath. And the way I do this is, I've heard a number of other people, and they've got good systems where they break it up into cardio and pulmonary causes. My personal favorite system is to think about the components that need to take place, or the processes that need to take place for a breath to be taken and oxygenation of the blood to occur and carbon dioxide to be removed. And this is what I'm going to show you now. So the first thing you need is a patent airway. That airway needs to be patent right from the oropharynx, the nasopharynx, down the trachea, the bronchi, the bronchioles, all the way down to the alveoli. Next, what you need is a chest wall that is capable of expanding. And what that expansion does is it generates a negative intrathoracic pressure. And if the lungs have room to expand, air follows the pressure gradient down from the atmosphere into the alveoli. So space for the lungs to expand, and of course, hand in hand with this is the need for alveoli to be able to be opened by air moving down a pressure gradient. And let's just call this compliant alveoli. Of course, oxygenation of the blood cannot happen without perfusion of these alveoli. And finally, you need to have an alveolar capillary membrane of an appropriate density to allow gas exchange to successfully occur. So, let's talk about what pathological processes can occur in each of these steps to create respiratory compromise that may present as shortness of breath. So, airway obstruction can diminish the patency of your airway. And I like to divide it straight off into upper airway obstruction and lower airway obstruction. Upper airway obstruction include things such as laryngeal edema, and that's often second to something like anaphylaxis. It includes the ingestion of a foreign body, remembering that a foreign body will most likely impact in the right main bronchus because the right main bronchus is more vertical, has a larger diameter, and is shorter than the left main bronchus. Right? There is also, in children particularly, an infective process called croup, most often caused by parainfluenza virus, but this is the technical name for this is laryngotracheobronchitis. Right? Then there's also lower airway obstruction, and you know these things such as asthma, COPD. You can also have bronchiolitis in pediatric populations. So that's your upper and lower airway obstruction called pathologies. Then let's talk about a chest wall that cannot expand. So of course, the main one that comes to my mind is traumatically injured patients with rib fractures. And if you have rib fractures, you are unable to generate that pressure and you're very worried about their respiratory status, particularly if they have a flail chest. You have patients with obesity, just because their chest wall is not as compliant. And you also have patients with your neuromuscular disorders. Things such as Guillain-Barré syndrome. Right? You need space for your lungs to expand given the negative intrathoracic pressure that's been created. And pathologies such as pneumothorax, hemothorax, a pleural effusion. These are all potential pathologies that can stop lungs from expanding. You need alveoli to be able to be opened. You need them to be compliant when air is driven into them. And of course, you can have transudates in the alveoli, and you can also have exudates. Remembering that the difference between transudates and exudates is that a transudate is without protein, and an exudate is normally due to an inflammatory or infectious process where part of the pathological process is increased vascular permeability. That increased vascular permeability allows proteins to exude into the alveoli. So you have a protein-filled exudative fluid. Transudative causes include things simply that are because of an increase in pressure in the pulmonary circulation, quite often due to left ventricular dysfunction. And that can be due to myocardial infarctions or congestive cardiac failure. Exudative processes, as you know, include things such as a pneumonia. You can also have collapse of alveoli because of recumbent positions, because of obesity, and that's known as atelectasis. Quite often happens in patients who are in hospital for a long time and aren't able to move and are lying down for long periods of time. Of course, you've got to have perfusion of the alveoli to allow blood to absorb oxygen and get rid of the carbon dioxide. And diseases such as pulmonary embolisms can stop perfusion of some alveoli. And essentially, when there's a mismatch of ventilation and perfusion, we call it a VQ mismatch. We'll talk a little bit more about it in this case. And of course, you need a membrane that is not too thick. And diseases that can cause an increase of thickness in the alveolar capillary membrane include all your interstitial lung diseases. And there are a number of them due to a number of causes. Some are idiopathic, some are related to smoking, some are related to the ingestion of dusts, and even some sort of rare viruses that can trigger this process. Now, this is a very comprehensive list of differential diagnoses, and you will never have to offer all of them. However, I think it's good to always have a system that can fit all of them into it. And I think this is one system that allows you to do that. Okay, so now that we've talked about that and we've given you a general system, let's talk a bit more about this case in particular. And something a lot of the older students who taught a lot of us said about these biomedical cases, which was so on point, was that everything they give you in these cases, they give you for a reason, and it's worth commenting about. They're all clues. So before you approach a case, try and identify these clues and help them formulate your diagnoses using these clues. So we've got a 52-year-old woman, and she's developed an acute onset of shortness of breath the day after laparoscopic cholecystectomy. So she's the day after surgery. The patient, who was previously well, she has a strong family history of ischemic heart disease and was a pack-a-day smoker. The examination findings revealed that she was obese, distressed, probably because of her respiratory status, she is tachypneic, and she had a non-productive cough. Listening to her chest showed decreased airway entry at the right base. There's no reason I double underlined that. That's a mistake. She is tachycardic. Blood pressure looks okay, a little bit low, if anything, for a woman who seems to be, has a few cardiovascular risk factors already. She's tachypneic, and she has a low-grade fever. Now, how are we going to structure our provisional and differential diagnoses? Because what the older students always told us was that the stronger students would provide a structure and show the examiners their thought process, whereas the students who are more used to memorizing this case would just sort of blurt out the main diagnoses. And what it really comes down to is choosing a provisional diagnosis and differential diagnoses that you can defend with facts from the case. You cannot just list out every one of the differential diagnoses I showed you on the page before this. You've got to be targeted towards this case. So in this case, I would say that my provisional diagnosis, and I'm sure it's all of your provisional diagnosis, given that this is an acute onset of shortness of breath, given that it's the day after surgery, given that this is a smoker, she's been immobilized in hospital, and that she is tachycardic, and of course tachypneic, she's acutely short of breath, and I guess has a low-grade fever. These clues all suggest that the strongest provisional diagnosis is that this woman has developed a pulmonary embolism. Right? Now, there are other differential diagnoses for this that we really should consider as well. So, differential diagnoses that may suggest that this woman has an airway obstruction is one of those things. And, for that matter, she may have swallowed a foreign body. She may be eating something and may have gone down her windpipe. She may have had an anaphylactic response to some of the medication she just received. She may have a lower airway obstruction. She's a smoker, so she could have pre-existing asthma. She could have an exacerbation of asthma. She's a smoker. She could have had an exacerbation of pre-existing COPD. There could be problems actually ventilating her alveoli. Perhaps she's developed a hospital-acquired pneumonia. We've talked about the perfusion disorder but more in terms of ventilation, she could have an acute pulmonary edema, and this could be secondary to a myocardial infarction she's suffering, or from congestive cardiac failure, given that she's had a history of ischemic heart disease, that she's a smoker, she's got cardiovascular risk factors. And one other thing in terms of ventilation, and that refers specifically to the examination finding of a decreased airway entry at the right base, is that she may actually have what we call atelectasis. Atelectasis literally means collapsed alveoli. And it commonly happens in people who are obese and in people who are in recumbent positions because they simply don't have, they're putting too much pressure on those alveoli to ever expand. And the way to fix this, as you've probably seen in hospital, is aggressive chest physio, getting them to really work hard on opening the airways that have collapse. So from my point of view, these are the main differential diagnoses that I would offer in this case. There are obviously more that you can offer, but these are the ones I think that fit specifically with this case. Okay, so now that we've gone through the case, let's go through the rest of the case protocol questions. So there's a question about factors predisposing to this disease. And before we get into that, I just want to go through some of the basics of what we're looking at, because I think that's quite frequently overlooked when you actually go through a case protocol. So let's be really clear about our definition of a pulmonary embolism. Pulmonary embolism is the occlusion of a pulmonary artery by an embolus. And we frequently only really think about the thromboembolism, which is the most important cause and the most common cause of a pulmonary embolism, but we shouldn't exclude that there are other causes of these emboli. Air, particularly in intravenous drug users, or they can be iatrogenic. So this is the reason why intravenous lines are primed before you actually start infusing fluids into people. That's to make sure all the air and air bubbles are out, because this is one of the risk factors for that. Fat, frequently in long bone fractures, but rightly and most commonly in this case, the most common cause is a thromboembolism, where a thrombus develops most frequently in the deep venous system of the lower limbs. So that's a deep venous thrombosis. And the factors specifically that may lead up to that can be covered by what's called Virchow's Triad. Now, you may have remembered that I talked about categorization in terms of differentials. Categorization in any answer will always help you remember and always show the examiner that you are thinking about things in a structured and logical fashion rather than pure memorization, right? And so whenever there is some sort of categorization system, I encourage you to name it and to try and use it. And Virchow's Triad works perfectly in this case. Essentially, I think about it as the ingredients needed for a thrombus to form. Now, thrombi don't necessarily have to be in the deep venous system of the lower limbs, as you know. So you can have deep venous thromboses. But Virchow's Triad also covers thrombi that may form in the coronary artery circulation, in the cerebrovascular circulation, and indeed in the heart as mural thrombi in the left atrium or the left ventricle. So this is actually a very good system for a number of cases you will cover soon. So it's very, very important to know it well. And the first part of Virchow's triad is a hypercoagulable state, suggesting that the blood is more prone to coagulate than it normally is. Now, these causes can be broken up into acquired and genetic causes. The acquired causes include factors such as surgery, and let's actually, while we go through this, let's asterisk these risk factors that this woman has. So the acquired risk factors include surgery, smoking, malignancy, and estrogen-containing drugs such as hormone replacement therapy and the oral contraceptive pill. Genetic factors you should be looking for in younger people who seem to be developing thrombi, and thromboembolic complications. And they include things such as factor V Leiden, protein C and S deficiency, and antithrombin 3 deficiency. And I want to talk a bit more about these on a later slide when we're looking at the coagulation cascade a bit more specifically, because these would be quite new to a lot of you. Right? So we've talked about hypercoagulable state. The second part of Virchow's triad is turbulent blood flow. Right? And you've already known this one from knowing that in people who have myocardial infarctions, who have altered left ventricular function, that these people, people who have MIs, can develop mural thrombi. People with AF are often anticoagulated because of the predisposition to develop a thrombus that may embolize into the systemic circulation. It's important to note that these left-sided thrombi will, in the majority of cases, never get to the right side of the circulation. And they only do in cases where you have something called a patent foramen ovale, and that's where there's a left to right shunt in the heart that didn't congenitally close at birth, and we can talk a bit more about this in our tutorial at Liverpool. But this is a very small amount of cases that you need to worry about. And the immobility that this woman has had since her hospital stay started, and that she's probably been in a recumbent position in a hospital bed for days. That's another reason why you can get turbulent blood flow in the lower limbs that may predispose to a deep venous thrombosis. Endothelial injury is the last component of Virchow's triad, and as you know, the big one here is atherosclerosis in the arterial system and atherosclerosis of the coronary artery circulation and the cerebrovascular circulation are what predisposes to myocardial infarctions and ischemic strokes, respectively. But surgery in itself in an area can cause injury to endothelium, and smoking is also something that stops natural endothelial function, which is to anticoagulate the blood and ensure that thrombi don't develop inside the circulation. Okay? Which leads us on to the coagulation cascade itself. We mentioned it a couple of times, and it is new. It hasn't been taught really in phase 2, so let's go through it slowly. The coagulation cascade is actually a part of the hemostatic mechanism. And its function is that the hemostatic mechanism's function is that if you lacerate a blood vessel and are bleeding from that blood vessel, the hemostatic mechanism, hemo meaning blood, static meaning stop, is designed to stop you exsanguinating or bleeding to death. And the way the hemostatic mechanism works is it first starts with a constriction of the blood vessel, so stopping the amount of blood that is going to the lacerated vessel, then an adhesion of platelets to the deficit in the vessel wall, and an activation of platelets. They aggregate together and pretty much plug the wall, so that's referred to as the platelet plug. I apologize for my spelling. And then finally, that platelet plug is reinforced by fibrin. And the process of producing fibrin is what the coagulation cascade is. It is the process of turning normal liquid blood into a gel or clot, right? And the blood has two different ways of doing this. It has an intrinsic pathway and an extrinsic pathway. And the difference in these two pathways, they both lead to the production of fibrin. So they both lead together into a common pathway that produces fibrin at the end. But they both approach this common pathway from different directions. The intrinsic pathway, the difference is it contains components that are just present in the blood. So this is the pathway that gets activated. I don't know if you've ever seen this, but if you take blood out of a human being and put it in a test tube, it will, after a little bit of time, coagulate. So that's the intrinsic pathway at work. Elements in the blood detect that this is not a natural surface and begin to coagulate. Extrinsic pathway is activated with components from outside the blood as well as components in the blood. So when you get a traumatic injury, you have tissue factor released from the damaged tissue that initiates this pathway. Again, both of them lead to the common pathway that produces fibrin, and we'll have a look at this in a diagrammatic representation in a second. And as I mentioned, both the extrinsic and intrinsic pathway result in essentially the common pathway. And what the common pathway is the conversion of factor 10 into factor 10A, and then factor 10A converts prothrombin into thrombin, and then thrombin converts fibrinogen into fibrin. Now, if a lot of these words are confusing, I promise you it is easier than it looks, and we'll have a look at the diagram in a second. And I think it's very important to mention that if this was the only system, your blood wouldn't be liquid. It would keep coagulating and turning into gel. So there is a very important regulation system. And that regulation system is governed by these things called protein C and S and antithrombin, and involve factor 5. So that's what we were mentioning before with inherited thrombophilic disorders. And we're going to talk about them more on the diagram. So this is the diagram I've been promising to show you. This is the coagulation cascade. Again, looks a lot more complicated than it is. The end result you need to realize is this. You get fibrin and it becomes stabilized. And that is liquid blood essentially at the top turning into this jelly or clot at the bottom. Right? And as I said, this is what ensures that when you bleed, you don't bleed out to death. But if you're not bleeding and this process occurs inside a blood vessel, that is what is a thrombosis, right? So you don't want this pathway to occur when there is no need for it to occur. And as I said, there's two different ways of approaching fibrin. There's the extrinsic pathway and the intrinsic pathway. Let's talk about the intrinsic one first. So if you have contact with a foreign substance such as glass, but it could be something like a stent, a foreign object in the body, you get factor 12 going to factor 12A. That activates factor 11 to go to factor 11A. That factor 11A activates factor 9 to go to factor 9A. You don't need to remember all these numbers. Probably good to remember what it starts with, and it's feeding into, below this line, the common pathway. So the extrinsic pathway and the extrinsic pathway in the intrinsic pathway feed into factor 10 to factor 10A. Factor 10A feeds into prothrombin, thrombin feeds into fibrinogen, turning into fibrin. Right? So this is a cascade of reactions that occurs to create fibrin. And we talked about the intrinsic pathway. The extrinsic pathway, as I mentioned, starts with tissue damage. Things such as tissue factor, phospholipids, calcium ions are leaked into the circulation. They activate factor 7A in the blood. that feeds into factor 10 and activates the common pathway. Now, as I mentioned, there needs to be some regulation of this pathway, or else we'll just have coagulation that happens all the time inside the blood, and it wouldn't be good. And that regulator, there's 3 of them that I think are worth talking about. The first one is antithrombin 3. So antithrombin 3, just forget the heparin for now. Antithrombin 3, it actually regulates all the coagulation enzymes, and it essentially stops them from initiating this cascade while there's nothing wrong, right? Makes sense? The other checks and balances on the system involve factor 5. Now, factor 5 is very important to help factor 10A convert prothrombin into thrombin. But there are these 2 proteins, protein C and protein S, and they're responsible for inactivating factor 5. Yes? And because they inactivate factor 5, this 10A isn't able to continue the pathway. Right? So we talked about 3 inherited coagulation disorders that make you hypercoagulable. And the first one was a deficiency of antithrombin 3. As you can see, if you don't have enough antithrombin 3, there is less inhibition of this and more chance of producing fibrin in the blood. Then you can also have a deficit of protein C and protein S. And if you don't have enough protein C and protein S, you're not going to you're not going to inhibit factor 5A, and you're going to have more fibrin produced. The last one, which we talked about, was something called factor 5 Leiden. And what factor 5 Leiden is a genetically mutated factor 5 protein that it has a change in structure, and that change in structure makes it resistant to inactivation by protein C and protein S. So if you have factor 5 Leiden, you have more activation of factor 10A, helping prothrombin turn into thrombin, and more fibrin produced. So you should just be aware of these inherited thrombophilic disorders, and you should think about them in cases of young people coming in with coronary artery occlusions, of ischemic strokes, of pulmonary embolisms, and they're only 20 and they don't have cardiovascular risk factors, they don't have any of Virchow's triad. You should be suspecting thrombophilic disorders. That's why they're relevant. Right, so there are actually a couple of really important tests that we run all the time clinically, and they're important to monitor the coagulation cascade. So these 2 different tests are essentially timing tests, looking at how long blood takes to clot and encouraging the blood to clot using the intrinsic or the extrinsic pathway. So the APTT is a time taken for the blood to clot when it uses the intrinsic and the common pathway. The PT time is the time taken for blood to clot when it uses the extrinsic and the common pathway. As you can tell, the longer the APTT or the longer the PT, the less the blood is coagulating and the poorer the function of the coagulation cascades. Alternatively, in people who have hypercoagulable states, these times will be shorter, right? Now, you will never see a PT test on a form. What you will normally see as a result is what's called the International Normalized Ratio, or INR. And what that does is look at the prothrombin time of the subject over the prothrombin time of a control. You multiply it by some sort of ratio, and that gives you a number called the INR. Now, 0.8 to 1.2 is normal, right? You're either exactly what the control is in terms of their prothrombin time, or you have a little bit of a faster prothrombin time, or you're a little bit slower, right? But that's normal. Anyone with an INR above 1.5 i.e. their blood clot's 1.5 times slower than a normal person, we say they have a coagulopathy. Or it's a therapeutic coagulopathy, right? But the target for a therapy to make you less prone to coagulate is normally 2 to 3 is the INR target, right? And even higher for people with mechanical heart valves, it's actually between 3 to 3.5. So that's something to keep in mind, and we're going to talk about these tests in a second when we talk about therapy. Now, the next question in the case protocol asks you to investigate this patient. And I just want to have a word about the general approach to how to investigate patients. So some people are big advocates of using the tests categorizing this by the tests you would run at the bedside, the blood tests you would run, any electrophysiological tests you would run, and then any imaging tests that you could run. Now that's one way, but given the amount of time you normally have in these biomedical examinations, I think the best way to make sure you get the most pertinent investigations across to the examiner is by talking about the investigations that will support your provisional diagnosis and the investigations that will rule out the important differential diagnoses. So let's talk about it in this case. So anytime you think of a deep venous thrombosis or a pulmonary embolism, you should always think about mentioning Wells criteria. And why it's important to mention is because this criteria actually stratifies your patient and actually guides you on what the most appropriate investigation is to run. Right, so we said it's a score used to stratify patients' risk of PE. And you don't actually need to remember this scoring system, but very simply, this woman, the PE is the most likely diagnosis as we discussed. She is tachycardic. She has been immobilized and has had surgery. We don't know about any of these other things, but she's clearly got a high risk score. It's above 4, it's actually 6 from what we can see. And that means the investigation of choice is a CT pulmonary angiogram, or in people who can't tolerate it, a ventilation to perfusion scan. Right? But it's the patients at low risk that this criteria is particularly good for, because a patient who is at low risk that you think it still might be something to do with a PE, you proceed to what a blood test called the D-dimer. The D-dimer is essentially a fibrin degradation product, and it's indicative of, sure, a thrombosis and an embolism, but can be elevated in a number of other conditions. The good thing about the D-dimer is if it's negative, it has a very high negative predictive value, and the PE can be safely excluded. If it's positive in these low-risk patients, then you proceed to the CTPA or the VQ scan anyway. But in this case, the way I would answer this question is I would assess this patient using Wells criteria, and given that she has a high risk, according to Wells criteria, would proceed directly to a CT pulmonary angiogram if her kidneys can tolerate it, or if not, a ventilation to perfusion scan. Now, I just want to show you what a CTPA of a person with a pulmonary embolism actually looks like. This is a cross-sectional CT scan with contrast of the chest. What you can see here is the aorta, the ascending aorta, the descending aorta, the esophagus, which is directly anterior to the descending aorta, anterior to the vertebral bodies, the spinal of the vertebral body, and here you can see the pulmonary trunk bifurcating to the left and right pulmonary artery, so this will be the right PA. And here you have the airway, because it's clear. The right bronchus here, the left bronchus here, you've got the right lung, you've got the left lung. And what you can see is the contrast in the pulmonary trunk is effectively filling the whole of the pulmonary artery. What a PE actually looks like is, let's identify quickly just to orientate. Remember, right lung, left lung, ascending aorta, descending aorta. This is your pulmonary trunk again, right? And what you can see is that the fluid, unlike the last picture, is not homogeneously filling the pulmonary trunk. You have these areas where you don't have the hyperdense contrast filling, right? And these are all filling defects that suggest that this patient has multiple pulmonary embolisms. Yep, so just compare once more this with this homogeneous picture here. So that's what a filling defect, that's what you're looking for when you do a CTPA. So that's the first and most important investigation that you would like to run in an ideal world. Remember, the goal of talking about investigations is not to list every investigation you know, but to be as selective of the investigations, to be economical and to save time and to ensure you get the best outcome, right? The other thing that is a good investigation to do that you can easily do at the bedside is an ECG. Now, the majority of patients with a pulmonary embolism, the most common sign is a sinus tachycardia. It is uncommon, but you will read about it to hear about new right axis deviation, a right bundle branch block, and an S1 Q3 T3 pattern. Now, this is something which a lot of people talk about, and they think it's, and sure, it does indicate a pulmonary embolism, but not all pulmonary, and a particularly large one, but definitely not all pulmonary embolisms do this, and very few actually do. So this is actually something which people say that's what they expect to find. It's not. The most common thing is actually a sinus tachycardia. Again, with the chest x-ray, even the case protocol encourages you to think of all these signs, but the most common chest x-ray finding for a person with a PE is normal, and it helps to exclude other potential pathologies. These things we can talk about more in the tutorial. I'll show you some pictures of them, but it'll take a bit of time now. An arterial blood gas is also very helpful, and the classic signs is you get a hypoxemia, a hypocapnia, and a respiratory alkalosis. And we'll have a look at the ABG in this case in a second and explain why you get this finding. You may want to do an electrolytes, urea, and creatinine, and that's essentially to check if the kidney function is appropriate for IV contrast, because if it isn't, you can always go to a VQ scan. You can do a lower limb duplex ultrasound looking for a deep venous thrombosis as well. And as I mentioned, in young patients, not this woman, she has enough risk factors, but you may want to do a thrombophilia screen, looking for those things such as an antithrombin 3 deficiency, protein C and S deficiency, and factor V Leiden. So let's talk about the arterial blood gas in this case. Okay, so this is the blood gas that they've given in the case protocol. And before we look at this specifically, I want to talk about a couple of things. I want to talk about the pathophysiology of this disease and how that will lead to a blood gas like this that we will see. And the second thing is I want to talk about the approach to reading blood gases, and it's an approach that you can use for every single blood gas you'll see in the biomedical examination. So let's start by firstly looking at the pathophysiology. So we've got this deep venous thrombosis, right? And it's in the deep venous system of the lower limbs. And the thrombus quite often extends. It doesn't embolize, it just grows along the vessel wall. And it can go right from the femoral vein, and I've read up to the external iliac vein. At some point, however, for it to become an embolus, it must actually dislodge and move upstream into the venous circulation to the common iliac vein, to the inferior vena cava, from there into the right atrium, from the right atrium into the right ventricle, from the right ventricle into the pulmonary artery, and it will occlude the vessel at some point where it becomes too big to go any further, essentially. Somewhere in the pulmonary circulation, it will start occluding blood flow. Now, what's the problem with this? I'm going to try and draw it, but I am a terrible artist. Say this is your vessel wall. And say this is going to split into multiple capillaries. But let's focus on one capillary, this last one. And say your embolus is here. So blood flow in this aspect of the pulmonary circulation just can't go through here. And you've got this vessel that goes, this capillary that goes here, and say you've got an alveoli that is here, and say, and in between those, the capillary and the alveoli, you know, is the alveolar capillary membrane. That's what the gas has to diffuse between. Now, what's actually happening at this alveoli is representative of what's happening everywhere beyond this occlusion point. So you are getting ventilation. Oxygen and air is still coming through the trachea and through the bronchi, through the bronchioles, and to these alveoli. However, you are getting no perfusion because of the occlusion of the pulmonary artery. And this is what's called a ventilation to perfusion mismatch. The most immediate effect of this is that you get low blood oxygenation, PaO2 falls, and you get hypoxic. What does that do? That hypoxic sense is transmitted to the respiratory center of the brainstem, and it's a chemotactic center, and it says you've got to breathe faster to get more oxygen. You've got to increase the frequency of your breathing and even the tidal volume to try and increase oxygenation. Now, what that does is actually increase the expiration of carbon dioxide. But if the embolus is big enough, you're not going to get increased oxygenation. And the reason why you can expire more CO2 but not obtain more oxygen is because CO2 diffuses much easier than oxygen. And there's a law called Henry's law which talks about this in physiology. You can read up about it, we can talk about it more. As a result, what you're left with is a situation where you have low PaO2, low PaCO2, and you become higher in pH or alkalotic because you have less CO2. So you become hypoxic, hypocapnic, and you become alkalotic. I hope that makes sense. We can talk about it more again, but I think it's really important to understand this process before we have a look at this blood gas. So let's have a look at this blood gas. And this is the way that we've always been taught to read blood gases. So the first thing you look at when you look at the blood gas, and you're looking for acid-base balance, is the pH. So the pH is clearly high at 7.5. Right? So we can tell from this that it is an alkalosis. The next step is to work out whether this alkalosis has a respiratory or a metabolic origin. So for that, we look at the PaCO2, and that's for the respiratory effects, and for the metabolic effects, we look at either the bicarbonate or the base excess. Normally, these are the same, but intensivists have previously said that the base excess is a more accurate representation of the metabolic status of a patient rather than bicarbonate for technical reasons. And again, those technical reasons take a while to explain, so we're not going to worry about it. But for our level, you can look at the bicarbonate or the base excess. And you essentially look at what is out of line. The PaCO2 is low, and that suggests that this alkalosis has a respiratory origin. If the base excess or the bicarbonate is high, it would be a mixed metabolic and respiratory alkalosis. And if it's low, it would be compensation for the respiratory alkalosis, right? However, here, both of them are within normal limits, so it suggests that there is no compensation. And obviously, they're not causing the alkalosis as the respiratory status is. The last thing to work out that we can see from this blood gas is that this patient is, as we predicted, hypoxic, and hence what we can conclude from this, a summarizing statement. I would probably interpret this in an exam situation just as we have now, by talking through your process of deduction and saying that this woman has a respiratory alkalosis without metabolic compensation, and hypoxia consistent with a type 1 respiratory failure. Remember, type 1 respiratory failure, often due to ventilation perfusion mismatches, and is identified by hypoxia without hypercapnia. And hypoxia plus hypercapnia suggests type 2 respiratory failure. We can talk about that more in the tutorial. But essentially, that's how I would interpret this blood gas. And I would say it is consistent with an acute respiratory failure secondary to a pulmonary embolism. Does that make sense? Great. So let's now talk about the management of this condition. This is getting to the pharmacological aspect of biomed. And unfortunately, quite often, pharmacology requires a large amount of rote memorization. But the thing that makes this easier is trying to fall back on as many principles as you can. The easiest way, the best way to manage a pulmonary embolism is to ensure that it never happens in the first place. And that is through making sure you are very, very committed to prophylaxis. And that includes compression stockings, includes either subcutaneous unfractionated heparin or subcutaneous low molecular weight heparin. You never need to know doses for biomed, so don't worry about this. And that's the best way of preventing a deep venous thrombosis in the first place and stopping the pulmonary embolism. But if you are in this situation, the one we're in now, the approach is to obviously manage this like a medical emergency. Look through your airway, breathing, circulation disorders, and then, provide analgesia if the patient's in pain, oxygenation, compression stockings, and really anticoagulate them. And we're going to talk about the mechanism of action, the side effects, the monitoring of these drugs in a second, but this is the regimen for patients. You really want to get them to this point where they're on warfarin. They can go home on warfarin, they don't need to be in hospital, and that's the goal you want to get there. But to get them there, you actually have to do this thing called bridging, right? And we're going to talk about why you have to bridge them. So you bridge them with heparin, right? Heparin you can use as an unfractionated form adjusted to the APTT that you want, or subcutaneous heparin at a predictable dose, right? There are your two options. Subcutaneous low molecular weight heparin or the IV unfractionated heparin, right? And you also give them warfarin. And what the heparin is for is essentially because in the first 2 days, when you start giving a patient warfarin, paradoxically, it actually gives you a hypercoagulable state. And we're going to talk about why. So you must cover that hypercoagulable state by giving them another anticoagulant, heparin, until their hypercoagulable state settles and the warfarin starts actually anticoagulating them. Right? And after you start seeing the anticoagulant effects of warfarin, you can cease the heparin and then probably discharge the patient because they don't need any more intravenous or subcutaneous drug therapy. Let's talk about this a little bit further. So let's talk about the mechanism of action of unfractionated heparin. So that's the heparin that we've talked about first. Now, how does this work? It actually potentiates the effects of antithrombin 3. Do you remember that drug, that enzyme? That's the regulator of the coagulation cascade. And what that results in is the inactivation of both thrombin, also called factor 2A, and 10A. And I think I have a, so we've got the coagulation cascade again. And so what heparin does, as this shows, is it potentiates antithrombin 3, and it potentiates it particularly in the case of inactivating factor 10A and factor 2A, which is thrombin, and it prevents the production of fibrin. Clear? Cool. Right? Monitoring of unfractionated heparin is very important, and we need to look at the APTT, and we adjust the unfractionated heparin until we get an APTT of between 60 and 90 seconds. But we also have to look at the platelet count, because heparin is associated with something called heparin-induced thrombocytopenia, i.e. a low platelet count because of heparin, and it's also associated with bleeding. So we have to look for whether this patient is bleeding anywhere. Quite often it's rectal bleeding or out of the urethra, so looking very closely at these things. As you know, the side effects of heparin are bleeding and bruising, hyperkalemia, and as I just mentioned, thrombocytopenia. Right? Now, important to contrast unfractionated heparin with low molecular weight heparin. Low molecular weight heparin, again, potentiates the effect of antithrombin 3, but it isn't actually able to inactivate factor 2A or thrombin. It only activates 10A, and we'll talk about why this is. Because it's smaller, it's more stable, and you don't need to monitor APTTs. It's got a predictable dose-response curve. It's less likely to cause thrombocytopenia, but it is more, both heparin and unfractionated heparin are excreted through the kidneys, so it is not used, but it is not used in AKI, acute kidney injury, or chronic kidney disease. In those patients, we actually use the unfractionated form, and we'll have to monitor APTTs, platelet counts, bleeding. It's got the same side effects as unfractionated heparin, however you have a lower risk of heparin-induced thrombocytopenia. And people prefer to use it because you don't have to monitor APTT times. Now, this is a diagram that explains why unfractionated heparin inactivates both factor 2A and factor 10A. You see, for a drug to affect antithrombin 3, so it affects factor 10A, all the drug has to do is bind to antithrombin 3. If it binds to antithrombin 3, it potentiates antithrombin 3, and antithrombin 3 will inactivate factor 10A. So that works for unfractionated heparin and low molecular weight heparin. It binds to antithrombin 3 and it inactivates factor 10A. However, to actually inactivate factor 2A, the heparin must not only bind to the to antithrombin 3, but also bind to factor 2A. Now, obviously, unfractionated heparin is a big molecule. It's able to do this. But low molecular weight heparin is so small, it's only able to bind antithrombin 3. That's why that's why low molecular weight heparin only inactivates factor 10A, and high molecular weight heparin or unfractionated heparin can inactivate both factor 10A and factor 2A. They might ask you about that. Then there's warfarin itself, right? So this is what we're eventually trying to get our patient onto so they can go home. So its mechanism of action is that it inhibits, I know this is a mouthful, but an enzyme called vitamin K epoxide reductase. And that enzyme is important in the synthesis of vitamin K dependent factors. So those factors, easy to remember by remembering the Australian TV channels 2, 7, 9, and 10. But it also antagonizes protein C and protein S. So hang on for a second. This is an anticoagulant drug, but not only does it inhibit the clotting factors, it's also inhibiting the clotting regulators. What does that mean for our patient? It means that, if we go back to this diagram, that sure, it will knock out 2, it will knock out factor 7, it will knock out factor 10, it will also knock out factor 9, right? So more extrinsic and common pathway. But it's also knocking out the things that inactivate factor 5. So what actually happens in the early days of warfarin use is that you get preferential inactivation of protein C and protein S before you get inactivation of all the clotting factors, and hence, because you have protein C and protein S deficiency, you actually get a procoagulant effect, which is the last thing you want in the first 2 days after initiating therapy. This is why we must bridge warfarin when we start it with heparin, which will inactivate the intrinsic pathway and the common pathway and compensate for this procoagulant effect of warfarin. So how do we monitor warfarin to make sure we are actually getting the anticoagulant effect? As you can imagine, because it's more active on the extrinsic and the common pathway, we look at the INR. And we wait for the INR to become 2 or 3. We also, like with any anticoagulant drug, look for bleeding signs and symptoms. And the principle of heparin therapy is that we cover warfarin with heparin until the INR reaches above 2, because protein C and protein S are inhibited before the procoagulant factors are inhibited, right? And that's the whole principle of bridging. The side effects of warfarin include that hemorrhage, as you can imagine, teratogens. It's a teratogen, so you would never give it in a pregnant woman. Skin necrosis, and numerous drug and dietary interactions, which makes it an absolute nightmare to monitor in the community. So these people, the first thing is they have to come back again and again to get their INR checked regularly. Their INR is affected by vitamin K dependent foods, and hence, so they have to watch their diet very closely, they have to watch their hydration status really closely, because that all affects their INR. So there is actually a new group of drugs called the NOACs, and we'll talk a bit more about these drugs in the tutorial, but they're novel oral anticoagulants. And they don't need monitoring. They pretty much do what warfarin does. They work actually directly on factor 10A. They're factor 10A inhibitors, a lot of them. And they're really good in the sense that you can discharge the patient, because like warfarin, it's an oral drug. The patient doesn't need to keep coming back to check how their INR is doing, because it's got a predictable dose response curve. But the problem with NOACs as opposed to warfarin is that they still don't have a reversal agent for NOACs. So if an old person with atrial fibrillation, for example, is put on a NOAC and has a slip in the bathroom and falls, fractures a hip, the patient on warfarin can easily receive fresh frozen plasma, which will reverse the effects of the warfarin. But a patient with a NOAC, we really don't have any antidote to that. And so really hard for emergency surgery patients. We'll talk more about it